Welcome everybody to our webinar. We will be starting in about 17 minutes from now. This webinar is, you might have already, obviously you have written it is on unruptured aneurysms, the state of the art care in the management of unruptured cerebral aneurysms. We request everyone to kindly keep their mics and their videos muted during the webinar, and because of obviously the bandwidth issues, and to provide more comfortable environment to our respected speaker. So you can use the chat box to send your questions, which will be conveyed to the speaker after the lecture ends, and we will be really happy to take up all your wonderful questions. And again, thank you very much for joining us today. It's a matter of real honor for us to have you here and to see so many people who are interested in neurosurgery and learning neurological surgery. And I really wish you to join our WhatsApp groups and stay updated for all our educational activities. Next month, we have got two activities, one with the Professor Robert Spassler. He will be delivering a state-of-the-art type lecture, and you will be so surprised. You will be really pleased to learn AVMs directly from the master of AVMs, and another lecture by Professor Michael Lawton. And for convenience and obviously to pay a lot of respect and tribute to our great legends in neurosurgery, these webinars will be solely taken up by these speakers, only like just one webinar with Professor Michael Lawton only, so that you can listen to him and have conversation, like you can send him questions, and we can do this type of interaction. And with Professor Robert Spassler, and obviously it will be on a very convenient time. We will try our best to select a time that is convenient for everyone around the world and for all the time zones that we've got. So and there is another webinar with the ISBN. Probably you all know that I'm also affiliated with the ISBN Education Committee, and we are conducted a course. The cycle one is already in progress, but you can join another cycle as well if you wish after the completion of the cycle one. However, you can still take up any module in the middle. So next week we have a webinar on epilepsy surgery that will be held on 27th of January. You can just get signed up for it. All the link is already up on the ISBN website. I will also share my links so that you can just follow our update from our Facebook pages and our WhatsApp groups. And we are all over in the social media. And there are also two webinars, one on Women's Day that will be held on in March, and 3rd of March, and another webinar on head trauma that will be held on the 20th of March. So we've got a lot of activities for you. And if you think that there is something we should arrange a webinar on, then kindly drop it in the chat box. And will be pleased to contact any master on that particular topic to invite him and to ask him to deliver a lecture. So again, thank you very much for coming, and we will be starting shortly. Hello, sir. Hello, Professor Jean. Hello. Professor Jean Oliveira is already here with us today. Hello, sir. Welcome. Hello, sir. Welcome. Hello, Professor Srindy Oliveira. We are really pleased to have you here with us today. Hello, sir.
Hello, good morning, everyone. Good morning from Brazil, but for you, it's good afternoon, right?
Exactly, sir. Thank you so much. Thank you so much, sir, for joining us today. It's a matter of real honor and pleasure for us to have you with us today.
Uh, thank you. Can I call you Maria, Dr. Maria?
Yes,
Exactly.
please. Exactly. So it's my
Yeah,
name.
Dr. Maria Noor. Yeah, I, I
Exactly.
am I am Jean de Oliveira. It's a great pleasure for me to be with you in this webinar and this session about intracranial aneurysms. Thank you very much for the kind invitation for the Pakistan Society of Neurosurgery. So thank you very much. It's going to be great,
Thank you so much, sir.
hopefully.
So it's so kind of you. Actually, I'm working with WFNS Education and Training Committee. I'm Pakistani. Originally I'm a Pakistani and I'm based in Pakistan. So it was a matter of great honor for me to run this World Congress of Neurosurgery for medical students and residents under the WFNS Education and Training Committee. So it's a real pleasure for me to organize all these webinars, especially for the trainees and for the students. And we owe a lot to teachers like you who always spare a lot from their very precious and very busy schedule. So we really wish to thank you and we are really grateful for you to spare your time to deliver this amazing lecture, which will be really helpful. Sir, would you like to check your screen sharing with us?
Yes, yes. Let
Thank you.
me. Are you seeing my screen?
Yes, sir, we can see. Thank you.
Yeah,
I hope you. Yeah, exactly. It's wonderful. It's running. Yes, sir.
perfect. Are you streaming this image for everybody already, or just for you and the director team, just to make sure that the videos are running well?
So we do have it's live stream on YouTube and neurosurgical.tv. You may try to you may try
Uh,
your videos as well so that we can.
let's see, let's see this. Uh, how about the video is running
Yes,
smooth? It's running well, or it's step by step? It's
from my
important for me. Uh,
for me, sir, for my side it is very smooth. I do think that for everyone it will be smooth because
yeah,
I
okay,
yes.
perfect, perfect. So uh, I'm uh, I'm up to you, okay? So as soon as you want, I'm ready to.
Thank you so much, sir. We are supposed to start our webinar in about 5 minutes from now, and Professor Luis Borba will be joining us shortly as well. And this program is also live streamed on neurosurgical.tv. People are joining us like slowly. We have got a lot of registrations in line, so they are going to join us, I think, shortly. And also there are viewers on neurosurgical.tv and on YouTube, so they are also viewing us live there. And all those people who want to really wish to send questions and get to
So
know a little better.
are you talking from Pakistan?
Yes, sir, I'm from Pakistan. I'm talking from Pakistan.
Okay,
Yes.
nice, nice.
Thank you so much, sir. Sir, I'm a young neurosurgeon
You
from. Yes.
you are in the head of which department in double FNS?
Sir, I'm in the Education and Training Committee of the WFNS and the
Okay,
BEATS. Yes,
okay.
and I'm also
Oh,
working for the BEATS committee. And with ISBN, I'm also organizing a course with the ISBN for BEATS neurosurgery. And there is another, and all of these are little varied. The third one is the executive board committee of the double ANS CNS section for brain tumors. So I'm actually affiliated with three of these committees internationally.
perfect, perfect.
A little diverse in that way. But everyone is so, I've seen that the teacher, the mentors internationally are really amazing. They're doing so much and supporting a lot of education all around the world. And it means so much because myself, I completed my training during this pandemic era, and I was quite, myself, I can feel it, that I was very apprehended
So,
back then.
so Maria, how much time I have for this lecture? Just to
Sir, this lecture is all about all with you. We do not have any other speaker because we really wish you to take as much time as you wish to in order to, I know it's comfortable for the speaker. Professor Borba always support this thing that you can take as much time as you wish because it's going to be. I know it's an interesting lecture, so you can just feel free and
okay.
just take as much as time as
I,
you wish. Yes,
thank you very much. I appreciate it.
thank you, sir. Because everyone wants to listen sometimes when we have a lot of speakers, so it's like we are compromising the lecture. Sometimes it looks very awkward and really bad, so I personally don't like it. And Professor Borba also always say that we should give time to the speaker and let them have a comfortable environment for them. So it's a pleasure, obviously, you spare a lot from your busy schedules, so it's something that we should consider, everyone.
Perfect. Let's wait for Professor Borba.
Yes, I think that he will be joining us shortly. I have messaged him as well. Our right time will start from about 2 minutes from now. I'm just seeing we have got. Sir, I have listened to so many of your talks, and I'm a big fan of all your talks. And I've seen your wonderful workshops as well with Professor Borba and others.
Yeah, yeah. Thank you for this comment. We have been in so many webinars along with Borba and all the team of the Latin America and also all around the world. So we are happy that we are giving some contribution for neurosurgical education all around the world. This is very important. Yeah.
Exactly. So it means a lot because it is like going to be a very high level of impact because all those neurosurgeons that are learning through you have having the privilege of learning directly from the masters. We could not even imagine or dream about it, although the pandemic was something very,
Yeah,
very, yes.
we
So,
are delighted to be part of this
and
amazing team that
so
Latin America and now World Federation is building for the more and more education for the neurosurgical young neurosurgeons all around the world.
exactly, sir, and it's a very big thing because obviously everyone who is going to learn will implement these teachings from you in their practice, and eventually it means to have a much better healthcare, especially in those areas like the low middle income countries where the training level is still not quite high as in the other countries much developed in neurosurgery. And I do think that it's a big step, sir. It's like not just a small step, it's a big leap for the neurosurgical community. So it's just like that. It's just like a moon landing. I think I just think it's synonymous.
Yeah, excellent, excellent.
So
Uh,
So I think that our time has started, the right time of our webinar. So if you wish, you can start now, or we can give about 5 minutes for more people if they wish to join the live session. Others are watching through neurosurgical.tv and obviously YouTube live. So if you say we can, if you like, we can wait for 5 minutes, or we can join, or we can start immediately. Sir, I think that if you say we can we start the webinar, if you wish, we can start the webinar now, as we can wait for about 5 minutes more. So whatever you say, I will be pleased to proceed it accordingly.
Okay, let's start. So
Yes.
again, let's start. Again, thank you very much for the World Federation of Neurosurgical Society and Education Committee for this kind invitation to be part of this amazing team that is building uh, excellence in the education neurosurgery all around the world. So today we're gonna talk about state of art in the management of unruptured aneurysms. Um, and I'd like to start talking from the beginning and then stepwise the way we use the evidence and the literature to dealing with patients with this so challenge disease, which is abrupted intracranial aneurysms. Uh, so I don't have disclosure to do regarding this presentation, and uh, the prevalence of abrupted intracranial aneurysm is very different among the studies in the literature. When we consider only retrospective autopsy studies, we see a lower prevalence incidence. The range of prevalence is around 0.4%. But when we go for prospective autopsy study, it's very higher number. It goes for 3.6% of prevalence. And then when we go for angiography studies, we see that the prevalence also keeps around 3.7% in retrospective studies. But when we analyze the prospective angiography study, you see the prevalence around 6%. So the prevalence depends of the way we study those patients, but we have to keep in mind that the prevalence is not so low as some studies trying to show us. So it can reach up to 6% in the whole number of people all around the world, independent of the area you are. But in general, the prevalence it's around 3% in the whole population without any comorbidity. Okay, and the mean age of 50 years, it's the mean, and the most of the studies, the men and women, it's half and half of the prevalence. But when we consider people with autosomic dominant diseases, like, for example, polycystic kidney disease, we can see a higher incidence in 6.9 and 3.4% when you have also positive family history of intracranial. So when you have comorbidity, when we have familiar uh, history, so the prevalence is higher. So this is the first step. Well, this guideline was published by American Heart Association, American Stroke Association, when they analyzed the number of people that have or the can have prevalence around 4,000 and 100,000. And when you compare these numbers with the annual incidence of subarachnoid hemorrhage, there is a discrepancy. And that suggests that only one rupture occurs among 200 or 400 patients per year. So this is very important. The number of the cases that we have is too much higher than the number of subarachnoid hemorrhage from intracranial aneurysm. So these numbers does not fit, and that's creates a lot of confusion, discussion, confusing interpretation of the incidence and prevalence of both a rupture aneurysm and the subarachnoid hemorrhage from those aneurysms. So this is important. Uh, let's see the next. Uh, so regarding the natural history, all those studies, retrospective studies, show different kinds of annual rupture rate. So every book, chapter, every single paper show us that the the incidence of annual rupture it's around 1 and 2% among those retrospective studies. When we go for I have some kind of delay to change my slide. Let's see what's happening over here. Uh, uh, are you seeing my screen?
Yes, sir, we can see the screen, but it is frozen on the
Uh,
natural history.
okay, it's frozen to me too. Let's see what's happening here. Just a minute, okay?
Sure, sir, thank you. No problem, sir.
Uh, let's open it again.
Yes, sir. So that happens very frequently. I think that nowadays, especially PowerPoint, they really need to update PowerPoint because it's happening with everyone right now. This PowerPoint issues are very, very
Okay,
common.
I don't know what's happening for any reason. The presentation stopped. Let's see. Just a minute.
Sure, sir. Please.
Let's try again.
Yes, sister.
Are you seeing my screen?
Yes, we can.
Let's see. Okay, I was talking about the retrospective studies in the natural history, and when you go for the prospective series studies, we see the new Izuya, which is the most famous, and two more Japanese papers showing the annual rupture around uh, among 0.7 up to 1.4%. And the most important data of the Izuya 2 is that aneurysm is less than 7 millimeters, especially in the group one, doesn't rupture. Only the chance and the risk of rupture is very low. So this information that comes from this paper is not what we have seen in the emergency room in the hospital all around the world. Uh, and there are a lot of data in the literature showing that even very small intracranial aneurysm, less than 3 millimeters in size, is still presenting with subarachnoid hemorrhage. So you have seen that even aneurysms less than 3 millimeters have a risk of that. Not only 7 millimeters, not only 5 millimeters inside, but aneurysms uh, with 3 millimeters or less than 3 millimeters. This paper show at least 100 cases, around 100 cases, less than 3 millimeters that presenting after subarachnoid hemorrhage. So this is the real situation that we have seen uh, in the emergency room in the hospitals all around the world. So I'm still having some problems to pass in the slides. I don't know what is happening here.
Sir, we can try if you just unshare the slideshow and then share again. Maybe there is some internet glitch that is causing a little bit of.
Uh,
Yes.
let's see. I'm going to try to share again. Uh, okay, are you seeing?
Yes, sir, we can see it now.
Okay, let's go through this. Okay, this is example. A patient, a young patient, 30, 31 years old, present with subarachnoid hemorrhage with intracranial hematoma on the left side, and we see the angio-CT, we see a very small, and there is in the MCA bifurcation. So this is what we have seen in our emergency room. And then when we talk with people all around the world that working in the emergency, we see the same situation. We can find patients with 10 millimeters, 7 millimeters, 5 millimeters, 3 millimeters that's still presenting with a rupture. So there is no rule that says if you have aneurysm less than 3 millimeters, there is no risk for rupture. Although it is written in very good papers like Izuya, it still is not what we have seen in the real practice regarding intracranial aneurysm. So the risk of rupture, it's ranges from 0% in some series up to 8.7%. So depend of the studies, depend of the country where you're performing the studies. We have different incidence of those uh, numbers. It doesn't matter where the studies are coming from. When you have a patient after subarachnoid hemorrhage, patient that has a ruptured aneurysm that ruptures and causes subarachnoid hemorrhage, those three studies show that at least 52% will die from the subarachnoid hemorrhage. This is the most important aspect. Uh, the aspect that it's going to rupture, it's not going to rupture, we cannot predict 100% that, but we can predict that if you have a patient with a subarachnoid hemorrhage from a previous diagnosed unruptured aneurysm, the patient have a risk of die at least 52% and can reach up to 86%. So we aren't talking about a very high mortality disease. So we have to avoid subarachnoid hemorrhage come from unruptured aneurysm. This is what we're going to talk about. This is what we're going to discuss more, because after aneurysm rupture, the risk of mortality is very high. And this is very clear in the guidelines from AHA or ASA that show that if you go for uh, following patients with unruptured aneurysm, we have uh, we have to to make anything. It doesn't matter if it's surgical or endovascular intervention. We have to treat. If you don't treat, we have to follow those patients with angio-CT or angio-MRI. We have to follow those patients to see if you have some kind of changing in the characteristics of the aneurysm. So this is very important. I'm not saying that we have to follow those unruptured cases. I used to say that you have to treat them, but if you cannot treat, or if the patient doesn't want to treat, we have to follow those patients, because the risk of subarachnoid hemorrhage is still up to the day if you go to occlude completely those aneurysms. I'm sorry, I'm still having some problems. Suddenly stopped to pass.
Sure, sir, it's okay. It's no problem. You all are having some sorts of issues with PowerPoint. Even yesterday, I was doing
Yeah,
presentation myself.
I'm gonna to occlude to close again
Sure, sir, please.
uh, and open it, because for any reason it still have some problem. Let's go. Okay. Try it again. Okay. So the decision-making process, it's not simple as we want, but we have three options: conservative treatment, microsurgery, and the vascular treatment. For cases like this, where you have aneurysm completely inside of the cavernous sinus, asymptomatic, I think the conservative management is the best option, because the patient doesn't have a risk of subarachnoid hemorrhage, and the patient is completely asymptomatic. So the conservative management for those cases is the first option. The same situation, the same location, the same size, the same patient, but with symptomatic intracavernous aneurysm. I think for those cases we have to treat them, because if you occlude those aneurysms, we can relieve the mass effect inside the cavernous sinus, and then we can relieve the symptoms of of the patient. Also, for patients that refuse craniotomy for any reason, the endovascular should be considered. And for those patients with elderly patients with poor clinical conditions and that have comorbid cardiac, some kind of problems that make the surgery a very, very high risk. So for those cases, I think the endovascular should be treated as the first option. Uh, uh, okay. Still, still, be endovascular first option for patients like this. This is a patient that we have 55 years old, present with infarct in the myocardium, the heart attack, and he had a stent in the coronary stent, and he was using double anti-aggregation. So for a patient like this, which is not a good patient for surgery, and it is a good patient for endovascular because it is already using uh, uh, some kind of medicine substance that is very good for endovascular treatment. So for situations like that, we have to consider endovascular. For all those situations, I think the microsurgery should be considered as the first option. And then uh, the first consideration to consider microsurgery is to master the neurosurgical approach. So as a neurosurgeon, we have to master and to know exactly how to reach every single area inside the skull, inside the cranium. And I'd like to recommend for you this amazing book that I have the privilege to co-editor along with Professor Luis Borba. In this book, we stepwise every single approach, and I think it's very interesting for any kind of neurosurgeons from the uh, young neurosurgeon up to a very experimented neurosurgeon. When you see a situation like that, MCA aneurysm, which was just clipped after pterional craniotomy, we are using intraoperative monitoring. So look at this moment in the surgery. This moment we have all information uh, about the patient. We have the anatomy, we have the microsurgical anatomy, microvascular, and now you are seeing the ICG fluorescence showing the flow in the artery. So we are having information regarding the flow, the uh, the intraoperative blood flow. We have seen the very small vessels, the perforating arteries, and also you have information regarding the function. Using the intraoperative monitoring, you have the function information also. So there is no any other technique to treat intracranial aneurysm that show so many information in a single procedure. So I have to say this is the most safe procedure to occlude the aneurysm, because if you have an intraoperative rupture, you can make a trapping or temporary clipping and stop the bleeding. Uh, you can see the anatomy of the vessels, you can see the flow, and also you can have information regarding the function. So this is the only technique that provides so many information in the single procedure. So this is the most safe procedure to occlude the aneurysms. And the recommendations uh, is surgical treatment for abruptly intracranial aneurysm is recommended to be performed at a high volume center. So this is important. If you work in a neurosurgical department that perform a very large amount of cases in a year, so the chance of good results is very high. If, on the other hand, if you have a small volume, a short volume of the case, so the chance of complications and the bad results are just there is class one and level of evidence B. And also you have to use specialized intraoperative tools that I just showed to you. You have to have a good microsurgical microscope. You have to have some kind of tool to analyze the flow, intraoperative angiograph, microdoppler, fluorescence with ICG or fluorescein. We have to have all information during the surgery. So this is very important. And again, there is a very good level of evidence for that. So unruptured intracranial aneurysm can be classified as an incidental, that there is no symptom, there is no sign of previous hemorrhage, and those that are some kind of mass effect symptoms, those symptomatic. And the third type is the additional one. When you have multiple intracranial aneurysm, one of them ruptured, the others are unruptured. So there are three types of unruptured aneurysm, and I'm going to show some illustrative case with different kinds that I've just talked to you. So this is a female, 36 years old, present with dizziness, and the MRI show a very small basilar tip aneurysm, and the angiograph confirmed that very small aneurysm, unruptured, incidental, because the symptoms of the patient was not related with the aneurysms. For this aneurysm, you have used the Pterion approach that is stepwise in the book. This is the way we perform the craniotomy with 3 bull holes, and the pterional craniotomy is it's the craniotomy. But after you expose the brain, the frontal temporal area, you have to keep the Sylvian fissure in the center of the surgery, because to open the Sylvian fissure is the key to reach the area where the aneurysm is. So for the basilar area, we have seen here the optic nerve after open the Sylvian fissure, the carotid artery, the carotid bifurcation, M1, A1, and there are 3 different pathways to reach the basilar artery. One of them is the bifurcation, which is not the best option, because we have a lot of perforating arteries in this region. We can go through the corridor between the optic nerve and the carotid artery, and also the corridor between the carotid artery and the third nerve. There are 3 options. I would say that this third option is the most common, but there are some situations like this where you have seen the corridor between the optic nerve and the carotid artery. After you open the liquid membrane, you see the perforatings in the P1, the ipsilateral, P1 contralateral, the aneurysm in the basilar tip. And you have seen the whole anatomy of the distal third of the basilar artery. You have seen the cerebellar, superior cerebellar bilateral, P1 bilateral, and then we have because it is a very small aneurysm, you have a space for clipping using this corridor. So after you put the clip, you still have seen the perforators, 2 perforations in this contralateral side and 1 perforation this side. And this is the postoperative angiograph confirming the complete occlusion. And this is the patient, the first postoperative day and the 1 month after surgery. So This is very important to have some kind of postoperative angiography to confirm the occlusion. So another example of completely incidental aneurysm. Look at this young male that was after a party in the university. He wake up with dizziness, and then in the neuroradiological assessment, we found this very complicated, and it was three lobulated with both vessels arising from uh, the neck in the base of the aneurysm. So this is very difficult. There's no good option in the endovascular techniques to occlude this aneurysm, preserving both vessels. And after Sylvian Fisher opened, we performed a temporary clipping, and because it was a large aneurysm, we start trying to coagulate in the wall of the aneurysm in order to make it smaller and easier for clipping reconstruction. In cases like this, we have to reconstruct the base of the aneurysm, trying to preserve both uh, vessels that arise from MCA. So this is a important situation. So this is a good technique, trying to make it smaller, trying to identify the perforating arteries that it's attached in the wall of the aneurysm. So look at how it's important to open the Sylvian fissure to gain space, to gain room. Uh, Here removing the temporary clipping, and then after we have a smaller aneurysm, we started to applying clips, preserving the origin of uh, both vessels that are rising from the MCA. So there was a small residual aneurysm right here, and then put additional clips, we could achieve a good complete occlusion of this aneurysm. So looking behind in the wall of the aneurysm and make sure that the both vessels are free. And now I'm checking the flow using the micro Doppler. So again, we have to have any kind of tool. In this case, we are using micro Doppler. So this is important, and this is the postoperative angiography, confirming that we could achieve a complete occlusion, preserving both vessels. So the reconstruction was achieved in this case. So it was a very good case. Look at again, it was a very young male. So this is a good result for that. Now it's another situation. It's a rupture intracranial aneurysm present with symptoms regarding the aneurysm. It's very difficult to say if the patient has a headache and the headache is because of the aneurysm or not. But when you have a symptomatic situation like a third nerve pulse, like in this case, the, we make the angiograph and see aneurysm in the posterior communicate segment of the carotid artery. So there is no doubt that these symptoms regarding this aneurysm. Uh, that patient went to another hospital. They decided to perform endovascular treatment for this aneurysm. And here is the final angiography after the final control, after put coils inside, and 6 months later, these coils were packed in the fundus of the aneurysm and the recanalization of the aneurysm. The patient returned uh, in the hospital where she was treated, and they decided to make another session of coils, and you see here final control, and if you analyze this, it was very good coil treatment because there's no area that still have some kind of feeling. But 6 months later, again, another recanalization. So after the second recanalization, the patient came to our hospital, and we decided to clip it. Fortunately, we still have some space right here to put a clip. So this is the optic nerve, this is the carotid artery, this is the free border of the tent. So now we have just treated the aneurysm because the clip you saw that was very simple. A single clip could occlude the aneurysm, but we now are trying to relieve the mass effect of the aneurysm that is full of uh, coils. We open the aneurysm that is already clipped and try to remove the coils. But after some months, the coils is completely attached in the wall of the aneurysm. So we had to cut the aneurysm and treat it like it was a tumor. Look at how the third nerve was attached and compressed by this uh, mass of coils, but we we still have trying to dissect it, to cut and remove the aneurysm and the coils. And now we have not only the complete occlusion, but also the mass effect relief. So you can see here the third nerve. And because we cut the aneurysm, we add additional clip to make sure that it is safe clipping. So in the postoperative angiograph, we confirm the complete occlusion, and we see that the patient uh, recovers from the third nerve palsy partially. She still has some kind of double vision, but she already improved 3 months after this last surgery. So it was unexpected uh, result because she was for so long, so many months, so long having a compression in the third nerve. So the timing is very important to to the nerve palsy relief and recovery. This is a paper that compared the results using clipping and coil for that, and shows that clipping is it's the efficacy of clipping for third nerve palsy, it's higher than coiling, and the time for recovery also it's faster. So this is very important data. There are more papers showing the same. In this paper, show the complete recover was 42% for coiling and 83% for clipping group. So the clipping group goes too much better when you have some kind of mass effect. And also the guidelines shows for us that when you have coil aneurysms, when you have a wider neck, so these are the cases that you have to follow, even when you have a good geographic result after coiling. Like the case that I'm showing, the final control was very good endovascular treatment using coils, but even when you have that, you have to follow because there is a risk for recanalization. So there is a very good evidence, class 1 level, evidence B, that you have to follow those cases because of the risk of recanalization. The symptoms regarding mass effect can be the third nerve palsy. You can have a hemiparesis when you have a giant aneurysm like this, a partially thrombosed MCA aneurysm that we treated like a tumor. You have to remove that, clip the neck, and remove the mass effect. But the most common uh, mass effect uh, is over the anterior optic pathways because of the incidence of the aneurysm arising from carotid artery and the relationship between the carotid and the optic apparatus. So it's very common to have visual deficit regarding the mass effect. When you have that, I have no doubt that we have to treat uh, these these patients. This is a good example. It's a very large aneurysm, and the patient was almost blinded, present with headache and progressive visual deficit. Uh, the angiographer confirmed the angio-CT with large aneurysm, and the 3D reconstruction show us that the neck of the aneurysm was almost completely englobed, encased by the aneurysm. So when you have a situation like this, we already know that the carotid reconstruction is not easy. We have to be prepared for a bypass in cases like that. We have to know about the collateral. So this is the balloon test occlusion, showing that the patient passing through the test. So we can occlude the carotid. It's not our final goal, but we already know pre-operatively that we can occlude the carotid artery. So again, we use the pterional approach. This is the position of the patient. We do not extend the head in cases like that. Uh, the surgery started in the neck because you have to have the proximal control in the neck, the carotid in the neck. So this is very important to have the proximal control. Again, the pterional approach regular. This is the subfacial uh, dissection to keep the fascial branch safe. We do not cut the muscle. We only detach the muscle from the bone. Those are the three boreholes that we perform. So this is a very uh, regular craniotomy. Again, our PowerPoint is having some problem.
So thank you so much for the wonderful lecture. We are waiting. Just I think that please take your time. I think this PowerPoint is a lot of troublesome
Okay.
for all of us. Yes.
Uh, well, let's see again. Sorry about that.
No, sir, not at all. No problem. We are all listening very eagerly and
Uh,
really.
up to now, the the videos are running well.
Yes, sir. Everything is running well. When it's running, it's all smooth. But sir, I think that
Okay.
yes. Otherwise, it's fine.
Okay, are you seeing again my screen?
Yes, sir. We can see.
Okay, so this is the craniorum pterional, the open the dura again. The open the Sylvan fissure is the key to have your way open. So you see, we are just cutting the arachnoid, and then you have a gain space. Look at the aneurysm. We already seen the aneurysm in this step of the surgery. You have seen the optic nerve right here. Look at how compressed it is. Look at how the carotid is englobed and encased by the aneurysm. You have seen here the posterior communicating third nerve, and also the very, very small branches perforating arteries that come from this region, and also anterior choroidal artery right here. And then this is important. Before before we start to try to occlude the aneurysm, in situations like that, we have to relieve the mass effect over the optic nerve. So we are open the dura that covers not only the anterior clinoid process, but also the dura that covers the roof of the optic canal. We have to remove this bone in order to relieve the mass effect. And then after that, we start to manipulate the aneurysm and the optic nerve. Because if you try to manipulate the nerve in this situation, we can create a, a definitive visual death. So it's very important to have a very small tip for the drill under irrigation and remove the bone from the clinoid and then bone of the roof of the optic canal. So I'm gonna pass faster here. So keeping the dura that covers the optic nerve to keep the nerve and safe. After we do that, open the optic canal, you see that the nerve is going to be free. So the bleeding that comes from the bone, it's easily stopped in using bone wax. The bleeding that comes from the cavernous sinus can be stopped using the fibrin glue. So this is the anterior uh, clinoid process removal. And then after removal the clinoid, you stop the bleeding, now using some kind of fibrin glue. And then you expose the clinoid segment of carotid artery. And now I'm cutting the distal dura ring. So cutting the distal dura ring, it's very important to manipulate the artery, to see the clinoid segment. And now look at its uh, safely to manipulate the nerve because now the nerve is free. Look at how compressed it was in the optic canal, but now the nerve is free. And we could see the origin of ophthalmic artery under the nerve, and we open the door, and now the nerve is free. Uh, and now we still open the distal dura ring, and now we have the whole anatomy exposed, the original ophthalmic, the aneurysm, the clinoid segment, the distal carotid. So now we can start to try to reconstruct the carotid artery and to occlude the aneurysm. So only after you expose everything, and then we have space to put the clip. So we are performing the trapping of the aneurysm, and now using suction. Look at how the suction of the aneurysm turns a very complex aneurysm in a not so complex aneurysm. Now using a fenestrated clip, you can try to reconstruct the carotid. Again, in cases like that, you have to be prepared for a bypass. But we could achieve a good uh, reconstruction using fenestrated clips. It was a very large aneurysm, almost giant, and the reconstruction was good. After the distal neck of the aneurysm, we could put a straight clips, not only fenestrated clips, to occlude this. And in cases like that, we have to have some kind of intraoperative angiograph. In this case, we have used the fluorescein. So now we have the original ophthalmic free, the carotid, the proximal carotid, distal carotid artery, and then we use fluorescein to analyze the flow. So you can see the flow in the carotid, the bifurcation A1, M1, And here is the anterocoroidal artery branches right here. So this is very important to make sure that you have uh, preserved the flow, not only in the big vessels, but in the very small vessels too. Again, the time is very important because we relieve the mass effect in very early stage. In this case, we could achieve a complete recovery of the visual depth. This is we have published about that in the neurosurgical focus, intracranial, and the reason presented with mass effect over the anterior optic pathways. In this paper, we analyzed the pathophysiology of the visual depth. Uh, sorry again. Let's stop here. Let's open again. So okay, so the pathophysiology of the visual depth is not only related to direct compression, as you are seeing this case. Look at the area of the optic nerve right here before the area which is compressed, and now look at how ischemic was there. So this is direct compression. So this is very simple pathophysiology. You have seen here the pulsation. The pulsation it's another kind of mechanism that created the visual depth. And the another situation is what we call the indirect compression. That it's exactly what we have seen in the previous case when the nerve is compressed inside the optic canal. And then when you have a thrombotic aneurysm with calcification in the wall, it's also a tough situation to relieve the mass effect. So we have to identify every single mechanism in those patients and try to relieve this in order to achieve the complete recovery of the visual deficit. So the visual deficit is not regarding a single mechanism. We can find different kind of situations in every single case that you use. So again, the guidelines have showed to us that early treatment is indicated for patients present with cranial nerve palsy caused by unruptured intracranial nerve. There is a class 1 level of evidence C that shows that the timing is very important. As early as you can relieve the mass effect, the higher is the chance of complete recovery. So this is very important, and this a strong evidence show that. And this is another situation that is the multiple intracranial aneurysm. When you have a ruptured aneurysm and others aneurysm that it's unruptured. So this is a good illustrative case showing this ruptured large MCA and other 3 unruptured cases in the same patient. So the recommendation here is try to occlude all aneurysms in the single stage, because as soon as you can occlude the all aneurysms, you can treat the complications of the subarachnoid hemorrhage early and more aggressively. So this is important. So after we clipped the MCA that was ruptured, look at here the origin of the anterior choroidal artery. So you put a clip in this angle in order to preserve the origin of all the vessels right here. So the ICG confirmed that the aneurysm is occluded and the vessels still open. Another unruptured right here. And there is additional aneurysm in the medial wall of this carotid artery that you cannot see from this stage of the surgery. So again, we have to open the cavernous sinus, remove the anterior clinoid process. I'm going to skip this because I have shown you already. Remove the anterior clinoid process, open the distal dural ring, expose the clinoid segment, stop the bleeding of the cavernous sinus using the fibrin glue. And now we can displace the carotid and see the medial wall aneurysm. We are using fenestrated clip, 3 fenestrated clip in order to occlude the totally the aneurysm. And the final ICG confirmed the complete occlusion, the good flow through the carotid. So this is uh, what we recommend for multiple intracranial aneurysms. Try to occlude all aneurysms in a single procedure. This is postoperative angio-CT. But of course, there are some locations, like in this patient, that have a bilateral peak common aneurysm, posterior communicating artery segment aneurysms, bilateral. So in most of these patients, we perform bilateral craniotomy. So we, in this case, first we treated this previously coiled aneurysm in the right side, and then some time 3 months later, we went to another side, another craniotomy. So bilateral craniotomy for treated posterior communicating artery aneurysms. So this is the most common treatment. But there are cases like this, is small posterior communicating aneurysm that we can try to occlude bilateral. So what I seeing here is the optic nerve right side, carotid artery right side, third nerve right side, aneurysm, and posterior communicating artery. So we are clipping through the right pterional craniotomy transfusion approach. So occluding the aneurysm, the right side. After you occlude the right side, what we try to do is look at the other side. But where is the aneurysm the other side? We cannot see the aneurysm. I can see the carotid, but I cannot see the aneurysm because the aneurysm it's in the blind corner by the left optic nerve. What we have done here is to put a piece of cotton between the both nerves, and then using the cotton, we displace the carotid, we displace the aneurysm. Now we can see the aneurysm right here. So here you see the posterior communicating artery. Here you see the aneurysm. This is the carotid. And here in the left side, you can see the anterior choroidal artery. So now yeah, I'm using a bayonet clip under the carotid. The carotid is right here, and put the clipping with directly visual of the posterior communicating and the anterior choroidal artery, and a safe clipping that was possible only because we displaced the aneurysm in the carotid artery using the piece of cotton. Now you see, and remove the cotton again. So this is a trick that we have used in order to achieve a contralateral clipping of posterior communicating artery. So it's a single craniotomy to clip both posterior communicating aneurysm. This is the postoperative angiography showing a complete occlusion bilateral. MCA, the same situation, a large aneurysm in the right side, smaller in the left side. So we perform a single craniotomy. It could achieve a complete occlusion. This is postoperative angiography confirming the complete occlusion. In this situation, the MCA became a little bit stenotic, but completely asymptomatic. When you have multiple aneurysms in the anterior circulation, it's one situation. But now I'm going to show you a different situation. This is a broad neck, large anterior communicating artery aneurysm and rupture, and also a basilar tip, high basilar tip, also unruptured. So now look at the distance between the posterior clinoid and the aneurysm. So different situations. For this kind of situation, we perform a optozygomatic craniotomy with the pretemporal approach. So this is the way we do COZ, expose the lateral wall of the orbit and also the zygoma. And then we have to have a big flap to reconstruct the skull base at the end of the surgery. Again, we only detach the muscle. We do not cut to the muscle. We do not leave a piece of dead muscle here. And then we just open the window of the zygoma and then pass the muscle through this window. In, in this manner, we can expose the whole tip of the temporal lobe in the base of middle fossa. So this is very important approach to this kind of aneurysm. This is stepwise in this chapter, in chapter 27 of our book, because this approach provides different routes, subfrontal, temporal polar, subtemporal, and transylvian routes. So we have at least 4 different routes to achieve the same area. So again, this is the exposure. The Sylvian fissure open is the keyhole to achieve a good exposition. So I'm gonna skip to accelerate the video, but just cutting the arachnoid, and then after open the Sylvian fissure, you have the whole exposure of the optic nerve, carotid artery, and we started to occluding the anterior communicating artery. So you see right now the contralateral left side optic nerve right here, the carotid bifurcation, and then we start to open the interhemispheric cister. When you open the interhemispheric cister, most of the cases we don't have to suction or aspirate the rectus gyrus. So this is a good technique to avoid to aspirate the gyrus rectus. So using a fenestrated clip, we could occlude this large broad neck aneurysm, preserving both A1 and A2 right here. Checking the flow and suction the aneurysm. It is important to make sure there is no flow inside and also to relieve the mass effect when you have. In this case, we don't have any mass effect. But you see here, both A2, both A1, Heubner right here. So it's important to make sure that all vessels are free from the clipping. Sometimes the clip stay after clip in a position over the nerve. So this is a good trick to remove the clip under the nerve. So what are you doing? It's press a stitch in the clip and skull base, and then you can retract the clipping and to remove the clipping over the nerve. So look at it, it's possible. So this is a good trick, a good technique to avoid the compression in the nerve by the clip. So now remember that this patient has another aneurysm in the basilar tip. So in cases like that, uh, look at the Transylvanian approach was perfect for clipping the anterior communicate, but when you open the uh, lyric membrane, you can see the basilar artery trunk right here, but we cannot see where the aneurysm, because the aneurysm is very high in this case. So for cases like that, we have to change our route. It's still a pretemporal approach, but we are working the Transylvanian route, but we're gonna change for a temporal route to come from this way to reach the most higher. Look at the contralateral third nerve, the SCA, PCA, but the aneurysm is almost in the in the roof of the third ventricle. So look at, we have to change our approach, the pretemporal, temporal polar route. So we are coagulating those small veins and then cutting the arachnoid from the middle fossa, and then cutting the arachnoid from the medial aspect of the temporal lobe. This is the freeboard of the tent. And now, as soon as you cut the arachnoid in the medial aspect, you see that the whole anatomy is appearing. So here is the third nerve, here's the P1, here's the SCA. So now we are gain space and changing the angle of the microscope. We have a different angle of approach, and now we have space to reach the most higher aspect of the basilar artery. So this is posterior communicating artery, and I was planning to sacrifice the posterior communicating artery in order to achieve a larger window, but look at how many perforators was arising from here. So I I changed my previous plan. Look at the contralateral P1, contralateral SC. There is a small perforating right here in P1, so I have to take care of this perforating artery right here. It's a kind of Pecheron pattern because it was a single perforating artery. Here is the contralateral uh, oculomotor nerve, P1, SCA contralateral. So I have a window to see that for ipsilateral there is no perforating artery. I can see the aneurysm right now, right here. The aneurysm was compressing the roof of the third ventricle. So now I can see the aneurysm. See? Now I can see the whole anatomy, which is complicated. So we performed a temporary clipping. So the first thing to put the temporary clip is to find a perforating free area. So we could find some area that was not having any perforation. So now we can dissect safely the aneurysm. Look at how the posterior communicate is in the middle of the way, but we still have some space to work. And was trying to see if there is any other perforating arteries, no perforating arteries. So now we remove the temporary clipping, put the definitive clipping, and the directed vision. Look at about the perforating arteries, and then we could puncture in a suction the aneurysm, no flow, and checking the flow of the vessels using microsurgical Doppler. So to master all those skill-based approaches, it's the key point to achieve the best results, independent of the region where the aneurysm is. So this is the post-operative angiograph show complete occlusion, the anterior communicating artery, and also again anterior communicating complete occlusion, and also in the basilar tip area. So I think I talked too much with you. I have two more cases in the posterior circulation. This is the pica aneurysm unruptured. It's very common in the posterior communication. Here is the far lateral approach. I'm going to skip here. This is performing the far lateral approach, removing the condyle, remove the C1, and then open the dura. And then you see here the vertebral artery, the pica arising from the neck or the base of the aneurysm. But when you have this completely exposed, now you have plenty of space for put a clip. And then we put a clip under direct vision. So again, what is difficult here? The difficulty is not to put the clip. The difficulty is perform the approach. So we have, again, to go to the lab, to learn how to do the approach, to refine our technique. Sorry, again, I'm gonna close and open almost in the end. Uh, uh, so this is the postoperative angio CT, 1 year follow-up, 3-year follow-up, and look at this tough case. At the beginning, I was thinking that this aneurysm was arising from the vertebral basilar, but when you see, in fact, it was arising from this vertebral artery right here, this hypoplastic vertebral artery with large aneurysm. Look at it right here. It was touching in the contralateral vertebral basilar junction. Again, the same position. We have two options. The stick incision of heteroauricular incision. Again, intraoperative monitoring is very important. Sorry. I've never had so many problems in a single lecture like we have faced it today, but okay.
Okay, sir,
Let's
it's very
see.
normal. It's very normal. I know we all know that we are all
Uh,
having this, glitches, technological glitches are everywhere.
uh, okay. Oh, okay. Are you seeing the screen?
Yes, sir.
So,
Perfect.
intraoperative monitoring, again, the same thing. Far lateral approach, removing C1 arch. Ah, let's keep that because it's all about the same. And let's move to the end of this presentation. Uh, okay. In order to conclude it,
No, it's okay. You can take your time. It's fine for us. We are
Okay,
all, yes, looking.
this paper illustrates as well how the currently the rupture aneurysms should be treated independent if you use microsurgery or if you use endovascular. The mortality and the morbidity of the treatment should be very low, because if you consider the risk of subarachnoid hemorrhage is 1 or 2% annually, and then you have a uh, uh, very low morbidity and mortality rate. You should consider treatment for almost every single case. So this paper illustrated that mortality 0.002, and this is another paper showing the mortality 0% mortality in the large series. And this is another paper that came from Mayo Clinic showing 100 consecutive patients with 47 cases clipping, 41 coiling, and 12 cases using both techniques. So that doesn't matter if you're using clipping, coiling, or you use a combination of that. You have to have a low morbidity and low mortality for those patients because most of them are asymptomatic of oligosymptomatic, and the decision making process should take in account different situations. There is no a single recommendation for any kind of patient for any neurosurgical department. Every neurosurgical team should consider the patient in the individual basis. We have to analyze the neurosurgical team experience. We have to see if you have the facilities that you need, like a good microscope, intraoperative monitoring, intraoperative blood flow analysis, ICG, microdoppler, the experience of the neuroanesthesia team, uh, the experience of the neurophysiology, and of course, the postoperative care in ICU. So we have to consider all the facilities that you have in the neurosurgical department. And also, we have to consider the patient characteristics, the age, the presentation, if the patient has some symptomatics, he had hematoma or not, mass effect over the third nerve or optic nerve, and also the psychological aspect. There is some patient that doesn't want to treat, to open the head, to make a craniotomy. And on the other hand, we have patients that when they discover that they have aneurysm, they want to be treated tomorrow. So we have to analyze the psychological aspect for every single patient. And at the end, the aneurysm, to analyze the aneurysm. It's a rupture aneurysm, not a rupture. If you have hematoma, subarachnoid hemorrhage, if they are symptomatic or not, the mass effect, multiplicit, more than one aneurysm, the size, the neck, the angioarchitecture of every single. After we analyze all those features and characteristics, and then we can decide if that specific case it's uh, um, it should be treated by clipping, by coiling, by stent, or should be followed. And so we have to treat those patients in an individual basis, based on the characteristics of the hospital, the patient, and the aneurysm. I think this is the most important message. And this is the beautiful building of the Santa Casa of São Paulo, where we work in the university, and we are pleased to host any visitor for any country all around the world. Most uh, uh, every one of you is most welcome to visit us anytime. So again, I'd like to thank you, the organization committee of the World Federation Education and Training Committee, and Dr. Maria, Professor Borba, and everyone involved in this educational webinar. Thank you very much for your attention. Sorry about the technical aspects.
Thank you very, very much, sir. It's a matter of huge honor and pleasure for us, and I think that we are so lucky to have you with us today and for this amazing lecture, sir. It means so much to us, and we really appreciate you. And I don't think we have the right words to express how much deeply honored and happy we are to listen to you, to have this privilege of listening to all the details and seeing your videos, especially and very detailed. You demonstrated each and everything so well, and I think that it's a treasure for us, and we are so lucky. We have all the recordings with us on our YouTube channel. I think we will, all of us will certainly like to go through them again. And thank you so much, sir, again. And obviously, we are so much pleased, and I think we will have the privilege someday to have the privilege of visiting your amazing institution in Sao Paulo. So many greetings to Sao Paulo from Pakistan and from worldwide. So this was an amazing lecture, sir. I you have very well described so many things, and I think that it means so much to us and all the attendees. Sir, there's another point of interest here, sir, for infundibulum. Sir, usually nobody, like they are not very high risk, the infundibulum in the vessels that we find. But sir, do you think, would you suggest any follow-up if there are any prudent risk factors for an infundibulum, such as a patient with some connective tissue disorders, or any family history of subarachnoid hemorrhage, or any aneurysm elsewhere, or if he had a history of aneurysm surgery? Would you like to follow up that infundibulum, although the risk is, I know, very, very rare for the infundibulum to rupture or to convert you into any sort of aneurysm? But
So
would you?
sorry, Maria. I'm having some problems to listen you. Can you speak slowly so I could not understand your question?
Sir, I was saying that the infundibulum, although the infundibula have a very, very, they rarely rupture or convert into any aneurysm. But would you recommend any follow-up if we find infundibulum in a patient with some
If you
history?
if I find what?
Infundibulum, sir, the vascular,
Ah, okay,
yes.
infundibular, and okay, okay.
Yes. So all those are, I know there's obviously they do not have any risk, much risk. They're very, very, very rare. But would you recommend follow-up if there is any history, like a family history of subarachnoid hemorrhage, or a personal history of patient with subarachnoid hemorrhage from any other aneurysm in any other site, or if there is some sort of connective tissue disorder in that patient? Would you recommend?
For infundibular
Mm.
situation, uh, there is some case reports in literature showing that infundibular became aneurysm. It's a very rare situation. I've never faced that, but I have seen a couple of case reports in the literature. But for infundibular artery dilatations, we just follow the patient using angio-CT annually. I've never faced any subarachnoid hemorrhage come from that. But if you go to the literature, you can't find it. Okay. What I have faced, it was infundible. We also published a paper, a case report about that. We had infundibular, and from the infundibular we had an aneurysm. So
Is it?
we could occlude the aneurysm and keep the original artery in the safe position because it was a posterior communicate artery with a fetal pattern. So in this situation, we have to preserve the posterior communicating artery. So we could occlude the aneurysm, but to preserve the infundibular artery where it was arising from the carotid. So this is important.
Exactly. So that's an incredibly important case, sir. Thank you so much for sharing, because I do think that it's a very important thing, especially regarding the fetal circulation. So there is a question. There are a couple of questions in the chat box, sir. One question is from Dr. Milan. He's asking that for follow up of incidental asymptomatic aneurysm, what is your preferred tool for radiological follow up, and at what interval of period you follow such patients? Thank you for showing a wonderful class.
Yeah, I I follow unruptured aneurysm only if I cannot treat them. So uh, there's a few situations that I recommended. Why I'm saying that? Because of the natural history. I started my lecture showing the data from the literature that has a lot of papers, strong evidence that uh, if aneurysm rupture, the risk of death is very high. So at least 52% of the patients will die after a subarachnoid hemorrhage. Uh, and those numbers can reach 86%. So we have to avoid that. So if the patient doesn't want to treat because somebody said to him or to her that you have a very small aneurysm, the risk of rupture is very low, so you don't need to treat. It's very common nowadays. The patient that came from a clinical neurologist or for another neurosurgeon that did not recommend any kind of treatment. Then the patient come to you to hear a second opinion. Okay, so when the patient came to me, and the patient, it's a good patient, there's no comorbidity, it's a young patient. That means when you have a young patient, that means you have a patient that will live at least more 50 years, 40 years. So the expectation of life is very high. And then you have the whole life to have subarachnoid hemorrhage. So we have to consider treatment for, because nowadays, currently, our morbidity and mortality is very low for the treatment. And the risk of death is very high, and if you have subarachnoid hemorrhage. When you put it in a balance, we have to recommend some kind of treatment, or microsurgery or endovascular, anything. But if for any reason the patient doesn't want to treat the aneurysm, or if the patient have no good conditions, clinical or psychological conditions to treat, I think for follow those patients, angio-CT, it's simple way to follow. Okay. Because it's available in almost every single hospital. It's a faster exam, so I think it's my first option. But of course, the gold standard diagnosis and the follow up is the angiography, the conventional angiography, because the image in the 3D reconstruction, the quality of the image is too much better.
Thank you so much, sir. Sir, when we started our medical school, not even our residency, when medical school, we taught that and brain aneurysm is like a ticking time bomb inside the head. So it was something that I still remember, that is a ticking time bomb inside the head. Sir, again, thank you for the answer, sir. What do you think about the recently? They are quite recently there's a rising interest in the wall imaging of aneurysms, like wall enhancements and wall imaging. Sir, do you think that they are really helpful for you in this case?
Again, it's very important to have. Uh, would be great to have some kind of tool, or some kind of examination assessment, just to say that aneurysm is never going to rupture, or that other aneurysm will rupture in 6 months. but we still don't have that. We don't have any kind of the information 100% that say, the wall of the aneurysm is saying that the aneurysm is safe. Unfortunately, we don't have this. So there, there are some papers coming with information that if you have inflammatory aspect of the wall of the aneurysm, so the risk of that aneurysm is higher for rupture. But for us neurosurgeons that look at the aneurysm closely, look at the wall, there is a lot of cases that we open, and then when you look the aneurysm, the wall it's very, very thin. We can see the flow inside the aneurysm, and then a simple touch in the wall, it ruptures. So, and there is no exam that can show it to us. So the risk of rupture is unpredictable up to now. So I think it's important to running studies to analyze that, but I don't think that currently uh, we can decide it if you go to follow or to go to treat the aneurysm using only the information coming from the wall of the aneurysm. I think it's very risky for the patient.
Thank you so much, sir. Again, sir, there is a very interesting case I know personally of. He's 82 years now, and he has a PCOM aneurysm of about 8 for 18 years, sir, and it never ruptured. It never caused him any problem. I'm really
80,
amazed.
80, 82
Two.
years old?
Yes, sir. 82 years old. So he's actually father of someone I know. So his son was very, very much, his son is almost 60 years old himself. So he was quite concerned that he really wished that to get operated. But obviously, there were risks, and his father was also not willing to get operated, sir. Sir, and he was diagnosed to have a PCOM aneurysm of about 18 years ago. And sir, he's totally it never bled, and he's totally stable. It looks very, very surprising for us.
I, what is the the problem of the endovascular technique? It's the risk of recanalization, the risk of rebleeding. It's higher when you compare clipping.
Exactly.
Okay,
Exactly.
but when you have a patient, an elderly patient, 82 years old, probably with 82 years old, the patient has hypertension, has diabetic, they have some kind of cardiac problem. So for patients like that, I think the endovascular management should be considered as the first option. And if you cannot do endovascular, or if recanalization occurs in 3, 4, 5 years, maybe those patients have any other complication from any other system before that. So for elderly patients with comorbidities, I think we should consider endovascular management. Uh, but if it's a younger patient, I would consider clipping.
Amazing, sir. Thank you so much, sir. So there's another question here. How reliable is balloon occlusion test for compensatory flow? At times, hemodynamic flow brings in late onset failure and ischemic complications.
Yeah, uh, the balloon test occlusion show us the situation of the collaterals at that moment, the moment of you perform the examination. Okay, under the conditions, the normal conditions, the patient, the blood pressure, you see. But during the surgery, sometimes you have different conditions. The patient is in the hypertension, they have some kind of bleeding, so it's under general anesthesia for so many hours. So the conditions are different, and then the brain can answer in a different way. But it's very important to know to analyze the preoperative collateral flow before the surgery. So I think it's a very important information that you can occlude or not the carotid artery, or if you have a good time to perform a bypass, when you have a balloon test occlusion positive, so it's a better for the patient. So in the risk are lower.
Thank you so much, sir. Again, sir, Professor Luis Borba has just joined us as well. Welcome, sir.
Hello, hello. Sorry for the, I was watching in another. Congratulations, Professor Jan, for always outstanding presentation. And I see a lot of people here that is still online. This unruptured aneurysm is still an issue that's coming more and more. Now, if the use of MRI, MRI, you can see a lot of very small aneurysms. Let me ask you one question just to end. 87 years old lady, okay? Does an MRI because have some cognitive dysfunction and find a small unruptured aneurysm of the ICA. What can I say? What should I say to the patient and to the family?
It's a very, first of all, it's a pleasure to be with my dear friend, Professor Borba, which is really one of our mentors here. It's always a tough question. Dr. Maria just asked me about the 82 years old patient with a rupture aneurysm, what to do. What I say to
not unruptured.
Unruptured.
Yes.
Unruptured. Yes. Now you came with 87 years old, unruptured, with some kind of comorbidities that is not related to the aneurysm, but which makes the case more difficult. What I say to the patient, I try to give the real situation about the natural history. That means that patient has some risk of bleeding, and if the aneurysm bleeding, the risk of death is high, very high, especially in an 87 years old patient. So I try to give this information to the family. So the risk of rupture exists, and if the aneurysm ruptured, the risk of death is high. The second information is we have two ways to avoid that. It's microsurgically and endovascular. I think for patients like you described right now, endovascular management should be considered because for patients with no comorbidities, it's a faster technique to try to occlude the aneurysm. And if you have some kind of recanalization in the future, we gain 3, 4, 5 years, and maybe this kind of patient will have other problems before the recanalization. So I would consider to treat endovascular. Which size is the aneurysm?
I make this question because you see, the endovascular for 87 years old lady with several morbidities is not so easy also. You can go with the catheter there, you can have ambulance, you can take a small plaque, you have complication. The majority of the people say that don't do anything. But a question they made is related to, especially to the young people that have this patient. You see, the decision should be made not just by the doctors, not just by the science, not just by the data, and explain to the family and explain the real situation. I ask you this because it happened with me 3 weeks ago. The same situation. And 2 weeks later, the aneurysm bled. Now patient in the ICU, in very bad condition. The family want to do surgery. They tried to do embolization, was not possible to do it. They couldn't go up with the catheter. And now we are treating a completely different patient in completely different situation. See, talk with the family, explain the real issue. The aneurysm will bleed. I don't know if you bleed in 1 week, 2 years, or never. Probably not have you need surgery, but we need to explain this, and the decision should be made just not only by the science and by the doctors, but especially talk with the family and explain the whole situation. We are seeing more and more this situation. We are seeing 3 millimeters aneurysm, 5 millimeter aneurysm, 3 millimeter aneurysm that bled. See, it's very important to understand and to analyze the situation. See, I think it will be the next questions to the treatment of aneurysm is unruptured aneurysm in elderly patients.
Yeah, it's a very
Thank you,
tough
Jean. Sorry
situation.
to bore you.
No, excellent example, because
Yeah.
we have to, the decision making process should be individual based, because every single case is different. I would say that all aneurysm is going to rupture someday. The problem is the people die from another disease before. So if everybody lives for 100 years, 120 years, of course the aneurysm is going to erupt in some point of the life. What happens today
Yeah.
is the people die for another disease before.
Yes, this is the question.
So there is another question in the chat box, which he wants to know that what do you think about the webs, the aneurysmal webs that are being increasingly used by the interventionalists nowadays? So do you think that they will one day be much more popular than any other intervention? He wishes to know.
Yeah, it's a difficult answer for that, because if we analyze the history of endovascular tools in the last 30 years, we have seen so many devices that came out, and nowadays we are not using any longer. So what happened with the patients that were treated using matrix? Probably nobody knows that matrix was a tool that was using 20 years ago. And what happened with the aneurysm in the patients that were treated using onyx or biocoils, devices that are not using anymore? So we don't know what happened with those patients, because those devices are not used any longer, and nowadays we have new devices. And if you go to see the papers, there are more than 100, 200, 500 new devices coming in the future and in use, in the experimental use, and most of them are going to the market, and part of them are not using. And those devices that you are using today, probably in a soon future is going to be out of the market. So it's very difficult to answer that questions. I think they still trying to find out some devices that can achieve a good occlusion like the clip can achieve nowadays, because although they came out with new devices, the result of complete occlusion is still low when you compare with the microsurgical clip. So it's very good. It's very difficult to say if the web device is still alive in the future, but I would say that probably no.
Exactly. So that's amazing. So there is another thing, interesting thing that I actually read in the literature that they have seen that those patients who are taking aspirin chronically are at a decreased risk of rupture, and if their aneurysm gets ruptured, they make a much better recovery. And it only applies to those people who are on long term use of aspirin, and not those who were like started aspirin later or new users. So do you really believe it is something of in reality something of real interest, or have you seen any experience in this?
Sorry, your sound is not clear for me. Can you repeat
Yeah,
that?
sure, sir. Sir, I actually read it in the literature that they have mentioned that those patients, they have seen that patients who are on a long-term use of aspirin, and when they were discovered to have an aneurysm, they had lower chances of rupture, and even those who ruptured had a better outcome. This and it was like a group of patients they who were on a long-term aspirin for some other reasons. Obviously, it could be most commonly it would be a CV reason or whatever. But even then, they had a much better prognosis. All those patients who are on long-term aspirin. So it looks very surprising. But do you have any experience that it could be true? Because it sounds surprising.
I don't have personal experience. What we have done in our patients is suspend the aspirin in previous the surgery. But for talking with the people that perform the endovascular, they say that there is no problem to perform surgery using aspirin only. The problem is those patients using aspirin for a long time. Uh, I don't know if it's if I rather read some papers saying that about the outcomes is better also. I have seen that, but I don't have a personal experience, and probably I will not have because I will suspend the aspirin always, because if you have a surgery uh, and you have a bleeding during the surgery that's not normal and you didn't suspend the aspirin, you have problems in the ethics in the hospital. You have to suspend that because we have some data show that's important. So, but I have seen some papers and I have talked with people that perform surgery in the patient using aspirin with no problem.
Yes, exactly. So it was something interesting and does not seem to be quite logical. So there is another question in the chat box I can see. Um, there is Dr. Maria Ellis. She wants to know, a person who operated on an unruptured brain aneurysm through clipping has a lot of mental confusion and forgetfulness. Is it normal?
It's a lot of mental what?
Mental confusion and forgetfulness. Is it normal? She hasn't mentioned the site or the preoperative, preoperative anything of the status of the patient. She just wants to
You
ask
see,
that they have operated on the patient, and I think that she means that she has operated on a patient who is now, and the patient is now suffering from confusion and forgetfulness, memory related issues, but she has not mentioned the site of the aneurysm.
but
No
the
further
death was
information.
pre-operative or post-operative death?
I think that she means that it was not present preoperatively and it is a new development after the surgery.
Uh, that can happen in any kind of treatment. If the patient has some kind of memory deficit or any kind of deficit, it probably is related to ischemic area in some region. If it came in the immediate postoperative time, usually it recovers in 48, 72 hours. But if it not recovers, probably if you perform an MRI, you see some kind of small ischemic area, but it can happen using clipping. If it can happen using any kind of endovascular tool also. In fact, it's more common when you use endovascular technique to have a ischemic accident during the surgery.
Great, thank you so much, sir.
Thank you. Thank you. It's my pleasure, my honor to be
Yes.
with you in this session.
Sir, there is another very important thing I really wish to mention. Sir, this program is being broadcasted by neurosurgical.tv, and this is being run by Professor John Bennett, and today is his birthday. So we really wish to extend our gratitude for his sponsorship, for his broadcasting collaboration with us, and we really want to wish him a very happy birthday today. His birthday is
Yes,
today.
yes.
Happy birthday, John.
Thank you. Thank you, John. Thank you again.
Thank you, John. It has been all possible. Everything he was quite a pioneer in this type of broadcasting, and obviously Professor Luis Parba, who has been a source of great inspiration and encouragement and support for all these wonderful activities. So we are all really grateful to Professor Luis Parba, and
Thank you.
thank you
Thank
so
you. You're
thank
doing
you.
a great job.
Thank you so much, sir. It means a lot to me. Thank you so much. You are so kind. And obviously, Professor Jin, thank you so much for your time and for the amazing lecture. It was really amazing. And because it is recorded, I think it will help so many people to learn much better. So it's a
Well,
huge privilege.
the
Thank you.
privilege is mine. The privilege is mine. Thank you very much for every one of you.
Thank you. Bye.
Bye, sir. Bye,
Ciao,
sir.
ciao. Ciao,
Ciao,
ciao, ciao.
sir. Thank you. Ciao, sir.
Ciao.
Ciao, ciao.
Thank you, sir. Thanks a lot, sir. So kind of you, sir. Thank you. Thank you. Bye. Thank you so much. Thank you so much, everyone, for coming today. Thank you so much. So kind of you. It was a wonderful time to see you all here and to meet you and to, receive your wonderful questions and everything. Okay. I'm just copying your email addresses, and we'll send you your certificates.